My name is Steve Kossor. I'm a psychologist. I've been licensed in Pennsylvania since 1981. And I actually started doing what later became called wraparound services in 1981. So I got a 10-year jump on everybody else. So we're looking at 30 years of experience doing this. And in the process of doing it, I realized that there were just rampant misunderstandings about the law, federal and state, and all of the requirements for the Medicaid Act and how it's applied in the schools and various other places. When I present this stuff, I go all over the country talking about Medicaid, because Medicaid is a national program with federal and state collaboration. And when I do these talks, most of the time I'm invited for a full day, and I go through the whole length and breadth of it. So this is going to be a bird bath. I'm an evangelist for EPSDT services in the strictest sense of the term. When you understand what EPSDT does, and I'll explain it pretty thoroughly today, you'll realize that it is the greatest treatment funding secret ever concealed. It's a colossal way of providing treatment services to children, and not just poor kids. In Pennsylvania and 35 other states, these services are accessible regardless of family income, because the disabled child under the age of 21 can be considered a family of one. And then that kid's income, he's 9 years old, how much does he make, you know? That kid's income becomes the basis for his enrollment in Medicaid, or at least the income requirement is waived. I'm understanding that the organization I put together in '96 called the Network for Behavior Change has now developed into the largest private psychology practice in the state of Pennsylvania that is devoted exclusively to work with children. And about 90% of our funding comes through EPSDT. I'm going to talk about Medicaid and education because it is managed differently in the home sector, the private community sector, and the education sector. We're going to talk about the Medicaid law, EPSDT, which stands for Early and Periodic Screening, Diagnostic, and Treatment Services. BHRS, which stands for Behavioral Health Rehabilitation Services. And BHRS is the actual name for what Pennsylvania went off the rails about 20 years ago and started calling it wraparound. Wraparound is a philosophy. It's not a mandate. It's not a federal entitlement like BHRS is. But by calling it wraparound and referring to it as wraparound, loads of people have been misinformed about what BHRS is and what the Medicaid Act mandates for disabled children under the age of 21 who are enrolled in Medicaid. We're going to talk about IDEA, the Individuals with Disabilities Education Act. It's morphed into Individuals with Disabilities Education Improvement Act. And then finally, the school-based mental health services, which in Pennsylvania are implemented through a program called the School-Based Access Program. Just so you understand a little bit about my credibility, forgive me, I'll blow my horn. This is a letter I got from the Centers for Medicare and Medicaid Services just last year, in fact, almost a year to the day, in which one of the directors at the CMS, which regulates Medicaid implementation across the country, she actually says, Mr. Kossor has indeed developed an effective approach to serving children and adolescents with developmental disabilities. In other words, she's recognizing that the material I'd sent to CMS for their review and approval met all of the CMS standards for Medicaid all over the country, including Guam or other territories. This is a letter that was sent to all of the state Medicaid directors. In Pennsylvania, the state Medicaid agency is the Department of Public Welfare. And this letter says, you can see the blue arrow, state Medicaid programs must make EPSDT services promptly available for any individual who is under 21 and who is eligible for Medicaid, whether or not that individual is receiving services under an approved HCBS waiver. Waivers are like a box of breath mints. You can rattle it and say, hey, Mrs. Jones, here's your waiver. Only 7 people in the state qualify for it. We only have limited funds. The waiting list is 8 years long. But here it is, it's free. That's a waiver. EPSDT is like a credit card with the child's name on it with an unlimited balance. And I'm not kidding about unlimited. You're going to see it in writing in a minute. EPSDT was created in 1967 to serve children under 21 years of age. It has a treatment and a prevention focus. The prevention focus is essential. In fact, some authorities say that the prevention focus of EPSDT is its primary focus. But in addition, it can fund physical, speech, and related therapies, hearing services, eye exams and eyeglasses, durable medical equipment, home, residential, and inpatient care, dental care, and other services, including mental health care. Most people don't have any idea that this exists, let alone how broad its coverage is. EPSDT is covered in the Social Security Act, which makes it a civil right. If a child's disabled under the age of 21 and enrolled in Medicaid, or even eligible for Medicaid enrollment, they are entitled under the Social Security Act to access to funding through the EPSDT mandate. Now listen carefully. For services that are sufficient in amount, duration, and scope to reasonably achieve the purpose for which they are furnished. Who determines the purpose for which a treatment is furnished? Answer A is the practitioner who saw the child face to face, did an assessment, and wrote a recommendation. That's one possibility. The other possibility is a licensed practitioner who sits in an airless, windowless room, has never seen the child, and only looks at the report shoved under the door, which the practitioner who prescribed it wrote. How many people think A is the only correct answer? The licensed practitioner who saw the child face to face is the only person who can determine the purpose for which a service is furnished. There's no question about that. And in every case that has been brought in the EPSDT legal world since 1967, that fact has been found to be true. So the bottom line, in the EPSDT world, licensed practitioners of the healing arts under scope of state law, and that would be psychologists in Pennsylvania, as well as psychiatrists, have almost sovereign authority to prescribe a course of treatment that will probably result in the amelioration or the cure of the child's condition, or the prevention of its worsening, or the maintenance of the child's functioning at a level at which he can reasonably or she can reasonably be expected to achieve with the treatment. So you really do, in Pennsylvania and most other states also grant psychologists the same authority, have the authority to prescribe what you feel is medically necessary for the child, and as long as what you are prescribing is not wildly psychotic, the chances are it'll be funded. But let's talk about wildly psychotic just for an example. Have you heard about hyperbaric oxygen therapy, HBOT? Now, I don't mean to connect those two in time as if I'm calling it wildly psychotic, but there are many people who doubt its veracity as a treatment. Nevertheless, in a federal court case in Georgia, HBOT was found to be coverable under EPSDT because it was found to be a treatment that worked. They took data before, they took data during, they took data afterward. The trends were uniformly down. The child's behavior became less disruptive, less problematic, and on the basis of those outcome data, HBOT was found to be fundable under EPSDT. That is how broad the EPSDT mandate actually is. Now, it's no secret why no state in the United States, including Pennsylvania, wants that little chestnut to be out amongst the citizenry. Note also that in the Social Security Act, it says that nothing, and this is in regard to the EPSDT mandate, nothing in this subchapter shall be construed as limiting providers of EPSDT services 2 providers who are qualified to provide all of the items and services described. In other words, you don't have to be eligible to do vision screenings or eye exams or dental or any of those other things. You can focus on behavioral health. You can focus on exactly what you're experts in and provide those services to children under EPSDT. In the EPSDT rules, there are essentially 3 services that are related to what psychologists do. The first is diagnostic services, and you'll notice it says here, recommended by a physician or other licensed practitioner. So you, as licensed practitioners, are fully able to do diagnostic services. There are also preventive services, which says provided by a physician. Now notice there's a difference. In diagnostic, it says recommended by. In preventive, it says provided by. The difference is a diagnostic evaluation can be performed by both the licensed practitioner and unlicensed people functioning under the practitioner's scope of practice. It does not have to be done exclusively by the psychologist. But if you're going to render preventive services, it cannot be rendered by other than the licensed psychologist. But the third thing that's critically important to licensed psychologists is this: rehabilitative services. They only need to be recommended by a psychologist or a physician, and that is what allows BHRS to be done in Pennsylvania the way I have been doing it for 20 years. You can think of a pyramid. I'm at the top, and I supervise 3 full-time equivalents of master's level mental health professionals, up to 3. That translates out to 120 clock hours per week of any activity done by people under my scope of practice. Each of those master's level people are allowed to supervise up to 9 bachelor's level people. So in the simplest rendition, there's me, and I supervise 3, and each of those 3 supervises 9. That's about 30 people under my scope of practice. Not only is that a reasonable amount of staff to be responsible for, but it's utterly doable as long as you've implemented standards for oversight and you have the clerical support to make sure stuff's getting done on time, that it meets the standard for clarity, it's legible, etc. I wouldn't try to stretch that too much. 9 people is a pretty whopping load for a master's level unlicensed person. In our experience, we try to keep it to 6. And if somebody's got a few years of experience, they can expand it. But you ultimately are responsible for the performance of the bachelor's level people as well as your direct supervisees. In fact, I'm responsible for the creation of that model in Pennsylvania. I challenged the psychology board back in '99 to say, wait a minute, a community mental health center can have 55 bachelor's level people being supervised by 1 person with a master's by attending a meeting at 7 o'clock in the morning once a week. That's ridiculous. You're going to allow that, and you're not going to let psychologists directly supervise these people with bachelor's degrees? That's nuts. And they agreed with me. And then they made other changes that made it necessary for the ratio of 1 to 9 to be applied across the board in the state. So I'm proud of that because I actually made a level playing field for psychologists. And by the way, what I'm talking about here is supervisory requirements of psychologists practicing privately. If you are employed by an agency, technically those people are not your supervisees. You're not responsible for them at all. They are employees of the agency, and it's a different world when you deal with agencies that are licensed rather than individual practitioners. The Network for Behavior Change is a group of licensed practitioners, so we hew to the psychology board's requirements and the DPW requirements as well. Very, very important. If you take nothing out of here, take this. This is Pennsylvania's official published rule about what is medically necessary treatment. Let's read it as a group. A service, procedure, or level of care that is necessary for the proper treatment or management of an illness, injury, or disability is one that will or is reasonably expected to prevent the onset of an illness, condition, injury, or disability, or one that will or is reasonably expected to reduce or ameliorate the physical, mental, or developmental effects of an illness, condition, injury, or disability, or will assist the recipient to achieve or maintain maximum functional capacity in performing daily activities, taking into account both the functional capacity of the recipient and those functional capacities that are appropriate for recipients of the same age. What's left? A service is medically necessary if it does any of those things. Most of the treatment we provide as mental health professionals do all three. So how is it then that an insurance company can stroll in and say, oh, that's not medically necessary? The medical assistance insurance providers have their own standards. Every company is different, every provider, practitioner is different. It's as if they're operating under different laws. Different agencies will tell their staff things that are patently not true. The managed care companies that monitor, and they're hired by the state and county government to control costs. That's why they exist. It was a waiver that had to be passed by the Social Security Act as an act of the state legislature to allow this to happen, because before that waiver was passed, you had a federal right under the Social Security Act to treatment from a practitioner of your choice. They had to change that to allow the managed care companies in, and they did in all 50 states. So the truth is, each managed care organization has implemented its own private standard of what they consider medically necessary. Some refer to Appendix T, the request for proposals. Some of them are in direct conflict with the state-identified definition of medically necessary services. Some of them are contradictory to it. Places that say that your child, because he is at level 3 or level 4 in Appendix T, he's only eligible for 20 hours a week. Stop. Where does it say 20 hours a week here? And in fact, in Appendix T, which they often cite as their authority, it doesn't say 20 hours there either. So the whole point is, if you want to go along and get along and play ball with a managed care company, you can. Or you can maintain an ethical stance as a licensed practitioner, which will probably run you afoul of your employer unless you're doing it privately. And that's what I'm doing with the Network for Behavior Change. If you're interacting with them and you cite the state regulations, you cite the federal regulations, they may still try to beat you down into a box. And the solution, the big answer here is you appeal, and appeal, and appeal, and appeal until you reach the state Medicaid agency, the Department of Public Welfare. And up until about a year and a half ago, when those appeals got to that level, the state Medicaid agency reliably and consistently implemented the federal law. About a year and a half ago, things started changing when the governor empowered the director of the Department of Public Welfare to do things that hadn't happened in the last 15 years, supporting managed care companies and literally saying to parents, hey, you don't like it, sue us. So there has become more of an adversarial relationship between the Department of Public Welfare and the people they're supposed to be protecting and caring for. And they are allowing managed care organizations much more freedom to implement their own imaginary vision of what is medically necessary. It's not as if this is the way things have always been. The federal law is absolutely clear. You're entitled to treatment that is sufficient in amount, duration, and scope to reasonably achieve the purpose for which it is furnished. That's federal law. That's the Medicaid statute. And any interference with that can only be done on the basis of medical necessity. So medical necessity is defined, wait a minute, to prevent, to treat, or to maintain. So how do you get around that you hire managed care companies to get around it, and when they get caught, they have to write a corrective action plan, and then things get temporarily reset. The problem is that the vast majority of people doing wraparound in this or BHRS in any other state, they have no idea about these laws. They listen to the insurance company and they believe the insurance company is telling them the truth, the whole truth, and nothing but the truth. And frankly, there are financial interests that most people have that make them leery about challenging these authorities. I've had my share of scrapes with insurance companies. They are scrupulous analysts of your practices. If you do something that's nefarious or hand in paperwork that's not legible, or you have it signed but they didn't include their highest relevant degree, the entire record is void. And if you're doing 20 hours a week and it's a habitual problem, you're going to wind up paying back an awful lot of money, and that's why your scrutiny over the quality of documentation is essential in getting this done. 3 key concepts to bear in mind about EPSDT, Medicaid, and education. The first is, as I keep saying, the services must be sufficient in amount, duration, and scope to reasonably achieve the purpose for which it was furnished. That's in the 42 Code of Federal Regulations, Chapter 4, Part 438.210. Secondly, EPSDT services must be provided to disabled children enrolled in Medicaid, whether or not the services are provided for in any state plan. Here's a quick pop quiz. What is the funding source that has never been cut in 48 years? EPSDT. I'm not kidding. When you ask, is EPSDT going to be cut? And you talk to the federal people at the CMS, they say, of course not. It's a federal mandate. The bottom line is, this is very important. Medicaid, not the school, must pay for covered services to a child if funding is in dispute. And in fact, according to the Individuals with Disabilities Education Act in '97 and the 2004 revision, Medicaid is actually the payer of first resort for services in schools. So whether it's funded by the home school district or not, the schools are allowed, and I'll show you why, to implement billing Medicaid for services that are already being funded by the local taxpayers. That's a real remarkable scenario. So bottom line, look under the Medicaid law, the Social Security Act, and it says also in that section, Medicaid, not the school system, must pay for covered services to a child even when these services have been found necessary and included in a child's IEP, Individual Education Plan, or Individual Family Service Plan, or IFSP. Medicaid law shall not restrict payment for covered services because such services are included in an IEP or IFSP. And then under the IDEA it says, if any public agency other than the educational agency is responsible for providing services under federal and state law, such public agency should fulfill that responsibility. So here's how they did it in Pennsylvania. Remember in 1989, the Omnibus Budget Reconciliation Act was passed, and in that act, Congress said that we don't care whether or not it's covered under any other part of state plan or whatever, EPSDT services must be available to fund treatment for disabled children covered by Medicaid. They made it mandatory in all 50 states. And about maybe a month after that was reality, James Tucker wrote this marketing letter from the Department of Education to all of the school districts saying basically the gravy train has arrived. And they turned that into a memorandum of understanding in which they laid out the standards under which the Department of Public Welfare would play ball with the Department of Education, and they made that an in perpetuity relationship so that every school district in Pennsylvania can bill Medicaid for services to children with IEPs. This is why every time a kid gets an IEP, there is a pretty assertive rush on the school district's part to get the parent's signature on the form to allow the school district to bill Medicaid. For some time there was a push within the departments of education nationwide to say, well, these are mandates, these are entitlements. We shouldn't have to ask parents for their permission to bill Medicaid. Well, of course, you still got to ask. The parent is still in charge of the child's education. Education has no encumbrance by managed care whatsoever. This is a separate pipeline into Medicaid. The guidance counselor's time is routinely billed, OT, PT, speech, transportation, and believe it or not, under the administrative claiming part, they can actually bill for advertising to fill those positions. The question is, and that's monitored by whom? This is a rhetorical question. I don't know the answer. DPW is the state Medicaid agency, but the question is, who actually monitors it? Because DPW offloaded the responsibility for monitoring to the managed care world. The managed care world has no responsibility for monitoring the education system. So it really is a rhetorical question. Who monitors this? And the answer is, I'm not sure. There is a wall between education and mental health. It's literally a wall. It's constructed by FERPA and HIPAA. FERPA is the Federal Education Rights and Privacy Act. HIPAA is the Health Insurance Portability and Accountability Act. They govern different sides of that wall. The only legitimate pipe through that wall is the parent. But you're going to see in a minute how schools subvert that in an attempt to just try to keep things manageable in classrooms and try to give a kid what the kid needs in the education world. But when that attempt goes off the rails, it costs insurance companies inappropriate spending. They wind up funding what amounts to education programs, and that's not appropriate. And then the education system winds up getting pushed into the realm of mental health treatment, which they are wholly incapable of managing. They can't even teach kids how to read, and they're going to teach them how to behave when they've got a mental illness. There's something fundamentally wrong with that. So let's look here at the Memorandum of Understanding that was created in 1989 that literally created a partnership between the Department of Public Welfare and the Department of Education that has since been developed into the School-Based Access Program. This is material taken from the website of Leader Services, which is the only entity in the state of Pennsylvania that is permitted by the Department of Public Welfare and Education to bill Medicaid for services provided by a school within a school district. And you can see here I've highlighted personal care assistant and psychology. The reason I did that, you look in the context, this is all the services that can be billed by a school district under the School-Based Access Program. It's a colossal list, isn't it? And here's the actual text document sent by the Department of Public Welfare to the Department of Education that literally establishes the health-related services a student receives through the SBAP, School-Based Access Program, are separate and apart from the MA services a child receives outside of the school setting. That's a quote with the large arrow. The smaller arrow quote says, additionally, there is no cap or limit on the total amount of money that may be paid by the MA program, medical assistance, for SBAP services or MA services that the MA-eligible child may receive outside of the school or inside of the school. There is no cap, and that's necessary in order to comply with federal law. Now, wait a minute. How can an insurance company say, whoa, Johnny only needs 15 hours of TSS because he isn't really acting up? Well, what about preventing him from getting worse? That he actually needs 25? Really? Or that to maintain his functioning and to avoid him going downhill in a month, he really needs 25? Really? The National Academy of Sciences in 2001 issued a book called Educating Children with Autism. It was called Educating simply because it was funded by the Department of Education. If you read the thing, it talks about mental health treatment, including discrete trial training and various other clinical behavioral psychology treatments. And in that book, they concluded, and this is based on an exhaustive study. By the way, the National Academy of Sciences was chartered by Congress more than 150 years ago to advise Congress about matters of science. So this august body did an exhaustive survey of the treatment literature and concluded that any child with an autism spectrum disorder requires a minimum of 25 hours of intensive individualized treatment per week in order to have a reasonable probability of recovery from autism symptoms. Now, all of you who work with kids on the autism spectrum knew this because the health insurance companies are telling you that 25 is the bottom number. No, I'm sorry, they don't do that. Okay? So bottom line, if a kid gets 5 hours of OT, PT, and speech combined, which is usually the little thin gruel bowl they get in a school, they get 5 hours there. That means the minimum that a kid with an autism spectrum diagnosis ought to be prescribed is 20 hours of TSS a week, minimum. The school-based access program employs personal care assistants, and they can bill up to $40 an hour. But wait, let's look at what the qualifications of a personal care assistant are. You have to have a GED. That's the best job on earth for people who never graduated from high school. You pass a child abuse and a criminal background check. You work for somebody who employs PCAs. Wait a minute, school districts employ PCAs, and they can bill Medicaid $40 an hour for their time. So the bottom line is school-based access up to the 05-06 school year had already taken $576 million from Medicaid as of 06. In the 08-09 year, this is the last year that Leader has published their data, by the way, because I keep publicizing it. In that year, look at the amount of money for PCAs. That's $32 million of a total budget of $112 million in the 08-09 school year. They took $140 million, if my sources are correct, from Medicaid last year alone. That's over $1 billion in the last decade just from Pennsylvania out of Medicaid. $50 billion nationwide. It's a colossal scandal because of the simple fact that the schools can take the money from Medicaid to reimburse their special education budget. And the only person who's certifying what those funds are used for is the school's whomever person who says, oh yeah, we use that for our special education budget. The superintendent and 8 of his buddies flew to Vegas for a week at a 5-star hotel to attend an education conference. That's just an example. Most of the time this stuff isn't even on a budget line item in a school district's budget. Now what's a PCA look like? A PCA is a TSS who wipes bottoms. You probably are going to have a fight to move a TSS in to where a PCA already is, but here's the truth. You can move a TSS in to teach a PCA who's basically a grandmother looking for some extra income, teach the grandmother fundamental skills of behavior management, and then the TSS withdraws, and the PCA is now equipped to better serve the needs of the child. I mean, that's one scenario. But the bottom line is, once a parent understands that they have a choice of getting a grandmother who can wipe their kid's bottom, or a trained behavioral person who gets 20 hours a year of training, an hour a week of supervision, they have to go through a rigorous vetting process, et cetera, et cetera. What is a sane parent going to choose? They'll always pick the TSS. So once they know what their choices are, and who's going to tell them what their choices are? The school? They're making money on the PCA, for God's sake. All right, so think of medical necessity. This is a direct quote from the Leader material, and I checked this out. It's accurate as of last night. These are quotes. Think of medical necessity as being medical educational necessity. What? Under IDEA, a child is entitled to a free, appropriate public education, FAPE, and in order for a child to receive this education, he or she must receive medical, mental health related services. So, consequently, staff wear 2 hats, one medical and one educational. Are you kidding? That is a definition of a conflict of interest. It's a dual role. It's an admission of a dual role. But nevertheless, this is the system we operate in. In 67, Medicaid's created, and 75 IDEAs created. 89, EPSDT became mandatory. Pennsylvania created a Memorandum of Understanding. A few years later, mandatory behavioral health managed care came into existence in Medicaid, and then the school-based access program began using Medicaid money without mandatory managed care interference. It drops right into the pipeline and funds programs under IDEA. When the mandatory managed care world came into existence, they realized that, wait a minute, we can stop paying for services in schools if the kid's already getting it through the school-based access program, or at least they thought they could. Some of the schools said, great, we don't have to worry about this mental health stuff anymore. We can offload it to the insurance companies and they'll worry about the kids' mental health needs. So then we have this fundamental dichotomy. You have an insurance company over there on the right, governed by HIPAA, that is rationing mental health treatment to kids. Their primary interest is to reduce or eliminate services so they can maximize their bottom line. Oh, wait a minute, they're also concerned about quality services. On the other side of that wall, you have FERPA governing the delivery of free, appropriate public education. That's the education side. And you have IDEA governing this and Medicaid governing this. The conduit between the two should be the parent, giving permission for the access of HIPAA information on one side and FERPA on the other side, and the only legitimate conduit through which that information should be shared. But now wait a minute, through the school-based access program, you create a second little pipeline here. But really, it doesn't have anything to do with managed care, but it does have to do with Medicaid. It starts to get really twisted. And the potential for a school district to be handed its head because of the misuse of Medicaid funds goes up and up. $20 million taken back in New Jersey last year. Phenomenal amounts of money coming back due to discovered irregularities in school districts' uses of Medicaid funds. So what's the solution? Here it is, mom and apple pie. You create an organization over here that meets the child's needs and enables the delivery of FAPE in the least restrictive environment. You have that organization run by and managed by licensed practitioners of the healing arts, like psychologists. They're responsive to HIPAA. They implement EPSDT. The parents, the conduit, FERPA's over here. These guys need to know what the school is expecting and doing and what they should be doing so that they can advise parents. The behavior specialist over here can advise the parent about education, rights, privileges, just simply by handing information to them. They don't have to counsel them. They just give them the information that the school may never have provided the parent with. And vice versa, if you get the people over here facilitating communication through the parent with the school, the parent becomes a more viable force in the kid's education life and holds the school more accountable, and everybody benefits from this model. So my recommendations, summing it up in the next minute or so. I want you to consider the benefits of contracting with behavioral health rehabilitation treatment providers for in-school mental health services who take outcome data from the recipients of services or their teachers or their parents, not just their own staff, and who are closely supervised by licensed mental health professionals with their own liability to manage and supervision standards to uphold, and who are implementing treatment plans identifying specific measurable outcomes that are school aware and incorporate evidence-based practices, including the wraparound model, which is an absolutely evidence-based concept. If you don't incorporate wraparound philosophy or procedure in the delivery of these mental health treatment services, they're not going to be as effective. And then finally, they're showing improvement in their clients' behavior because they are using objective data to update treatment plan programs conscientiously to achieve that goal. Now, this is hot off the press too. I've been involved in ongoing research for years and years, and we have over 1,500 records in our database now of BHRS outcomes for children going back to 2002. Because of the hiring of people who were not always spot on in their data collection practices and bumps that are inevitable, we have effectively created a random sample of children who got BHRS and especially TSS service. So what you see here is in this study we had 23 kids, a total of 53 treatment plans. TSS treatment delivery ranged from just 28 days to almost 5 years. We had treatment periods with no TSS, a treatment period, and then no TSS afterward. We did that by looking at our employment records. So here is a case where we had 28 days in this treatment period here. We looked at the 4 weeks before the 28 days and the 4 weeks after the 28 days. And what we found is that the average term in treatment for all 1,500 of these cases was 1.4 years. 90% of the kids we've worked with in the last decade have finished their BHRS involvement with us in less than 3 years. First, we found no difference between autism spectrum disorders, ADHD, any other diagnoses, ages, genders, or ethnicity. The same results were found across the board. First, there was no difference when treatment was interrupted. In other words, if there was a week here or so that the child didn't get TSS service, the kid's behavior did not sink to the bottom or climb to the top. There was no significant change. And when we had interruptions, multiple interruptions, no more than 3 in that treatment period, we found consistently that the effect of the TSS carried over in the time period when there was a lapse in service delivery. The parents reported on a scale from 1 to 10, a Likert scale, how frequently has your child displayed the target behavior, and then how severe was that display. You average those two numbers and you come up with a single number on a scale of 1 to 10 that the parent is asked every single week by the behavior specialist. It takes maybe 5 minutes to collect that data. But when you're done with an entire treatment period, you've got single subject with repeated measures, and it can be analyzed in any number of ways. Our analysis showed a significant reduction in all outcome measures. Now, not every child's treatment plan includes 5, they include 3. But every one of these domains showed a reduction in target behavior that was statistically significant after the end of the treatment period, even if it was a short one. 4 weeks post-treatment, virtually everybody we treat shows improvement. The recidivism rate is pretty low because there are thousands of kids in any given county who are eligible for wraparound, and the entire enrollment in Chester County alone was less than 1/10 of that population. So you have literally 10 times as many kids eligible for EPSDT as are receiving it. So if there was a high recidivism rate, those numbers would keep climbing, and they don't. In fact, they're staying pretty low. The only reason they stay so low is because nobody's advertising that these services exist. So what I've done is I created a model where we put BHRS in a wraparound cup, and I think we've created a model that produces effective treatment in a wraparound cup, and everybody benefits from this model.